actually, I brought a couple things because I wanted to show you that when we use simulation to develop our small baby unit, we didn't use fancy equipment. We used what we had, and I just brought a couple examples to show you guys. I'm going to put this on real quick. No, I think I got it. Well, that's going to sound terrible. That guy's going to yell at me. All right. Be right with you. He said, take off your necklace. Don't scratch with your... Oh, there we go. Can everybody hear me okay? All right, so I'm going to take a little bit different take than what Sue was talking about. She was really focusing on overall what simulation can be done for you. And my goal today was to show you how we use simulation for education for our staff to open a small baby unit. And I think I've got some credibility. I've been a NICU nurse for a very long time. I was a supervisor at Helen DeVos. We're a 108-bed unit with 300 staff. So our goal was to open a small baby unit, but we also realized that, once again, you can't train 300 people. You want to make sure that at least when you start out that you have a core team. So we really wanted to be thoughtful about it. We went out to Children's Hospital of California, and they actually had a small baby unit. And I can tell you that they didn't have any fancy equipment. They didn't have anything that was that different than ours. I mean, we had all this stuff, but it was the culture. And the culture is probably the hardest thing to change when you're talking about asking people to go from, and I was one of them, task-oriented, every 3 hours, get my stuff done, to paying attention to the cues of the baby, paying attention to that neurodevelopmental supportive care that we were trying to do. And we saw that out there, and it was just such a cool thing. And they have our references out there. I'll be happy to get them to you, but they did some great papers. Minnie Morris did a really nice job in a paper on the developmental outcomes and the improvement that they had once they opened their small baby unit. It took them, she said, about 4 years to really get to the point where they felt like it was ingrained in their culture. And because they had so many things in place, we stole shamelessly, and we really followed a lot of the models that they did, and we were able to do it within a year. I know that seems like a long time, but since we've done so many site visits now, I'm starting to hear people say, oh, we can do it in 6 months because there's so much stuff out there that we can share, we can give you, that kind of thing. So our aim for this project was to change our management of infants less than 27 weeks by training. We started out with 60 caregivers to work in a designated small baby unit. We picked that number because we felt like we could staff on a regular basis with those core trained people. Lots happened since then. We've trained a lot more, but that's really where we wanted to start. And this was just the kids that were 27 weeks and less. I'll tell you that that's 60 kids, about 60 kids a year for us. If we took it all the way up to 1,500 grams, that'd be 250 kids. And we wanted to start small so that we could do lots of PDSA cycles and tests of change to go along with that. So how are we going to get there? The two drivers we decided on was to develop the small baby team and to have a small baby unit. In order to get the small baby team trained, we took 4 days and really thought this out with the education, thanks to our educator at the time, and a core group. And we said, let's do it with simulation so that so everybody can practice and really see what it's like to take care of a baby and not do that task-oriented. We did hybrid learning, and I'll tell you that if you're in school now, that seems to be the trend, but we gave the staff tons and tons, well, not tons, we gave them 15 articles that we had our physicians pick out, and they had to do a blog and talk about those articles before they even did the simulation. And the reason why we did that is because we wanted them to be able to understand the pathophysiology of the way they took care of these kids. And I'm going to show you a little bit of an example of that. Plus, I have a really great video of one of our nurses doing an orientation for our staff. And you'll hear how, when she speaks, I want you to really pay attention that she doesn't feed them. She says, okay, so here we have a baby. Why is it important for me to keep the hips below the baby's head? You know, why is it? And it's just, she just does a really nice job. I can't even duplicate it. And then we also used video ethnology. And what do I mean by that is that we actually videotaped. I used my phone, Sue uses her phone, or just a little flip camera, and tried to do a before and after, how we took care, tried to do one-person care with, let's say, suctioning and doing CPAP, what that was like. And it's really interesting because there was a lot of pictures of the baby showing all those cues of please don't touch me and my heart's dropping. And you know, it's not that she wasn't doing good care, but there wasn't another person in there to tell her, we need another person, slow down, baby needs to recover from this. Let's just give it a second. Okay, now's a good time. I've got my hands on that baby. So we really promote two-person care. And I'll tell you that seeing those videos was so impressive for our staff that we decided to roll it out to any baby at any age that's getting a painful procedure. Particularly with the smaller babies, we always do two hands on those kids, but even the older kids deserve that comfort and that calming ability. So that we did huge training on using simulation for all the staff on two-person care for that reason. So let me just keep going here. So I'm not going to go through this. This is a very long timeline. I told you it took us a year. Started out with the planning and had classes. It was very important to us that we allowed anybody, so you didn't get into that elitism, if you will. We invited anybody that wanted to be trained through this to come and train, even our new staff. We just managed it so that we put them a little bit later in the year. We started out with more seasoned nurses and then put it later so they still had time on the unit to really get their skills down. And we also had them sign something saying that they would be willing to support a lot of PDSA cycles and tests of change because we knew this wasn't going to be easy. This was a big change for them, and we needed a very positive, like people really willing to accept that change and be okay with it. So here we are a year later. There was our first graduate. You can see Sebastian up there with his little hat on, and there's our core team, but it took time. Lots of little PDSA. We had to practice, you know, how dark do you make the room? How quiet? We started out whispering, and everybody's like, we had one doctor that has a little bit of a hearing. I can't hear anybody. So we went from doing this to just talking with a little bit lower voice. And we did lots of measurements, lots of sound measurements. We practiced with the lightings. We made it very, very dark in there at first. Staff came out, I have a headache, I can't see my computer. So re-looking at those things and listening to the staff and changing. Some of the ways we used simulation was we did, and this is one of our staff members, she was really excited to be able to play, but we just, you know, had them do skin to skin with the mom and had the staff work and how many people. You'll see that in the video I'm going to show you. We actually put kids on skin to skin on an oscillator, and we wanted to make sure that that was safe and we had the right people and people understood how to do it, because obviously safety is number one. We used it for admission. We used it for two-person care. We had 3 stations set up where each of the staff went to each station for an hour and practiced with the trainers. And the trainers were other bedside nurses. So we worked with them first, got it down, and then they trained the other staff. And it went really well because their peers have the credibility to you know, and they trust them. I think one thing I really wanted to focus on too is this focusing on changing the language with parents. We had one of our parents do that video ethnology where she actually interviewed parents that had graduated. And these kids, I think one of them was about 2 years old, and then one was like 8, and then all the way up to teenagers. And really talk to them about what happened in the unit, what they experienced, where their kids are now, what kind of things they struggle with years and years down the line, because we're really good at getting these kids home alive. In fact, we have a very good survival rate in our unit. But the one thing we didn't have is we saw a lot of kids with minor morbidities down the road with feeding aversion, walking on their toes, couldn't stand sound. You heard the parent talk this morning about all the things that Holland's dealing with now. And we were hoping, I know there's not huge evidence that says, you know, by doing this, it's going to change long term, but why not try? It makes sense. It's intuitive. We know that we would never let our 3-year-olds sit in a doctor's office and get a bunch of painful things done without holding them and caring for them and paying attention, saying, wait a minute, let me just, you know, comfort him. So we really wanted to look at that. And the other part of this is when we did the videos with the parents, they kept using words like stable. And, you know, he wasn't stable enough for me to take out. Well, what does stable mean? It's very different for each of us. So really changing our language and also inviting the parents in. We feel like they should be the second person with their hands on that baby. Can't always happen, but you know, we really want to encourage them to be part of that team. And then the last one was open to crucial conversations. You open a unit and you're asking everybody to be quiet. What happens when somebody comes in, or a subspecialist comes in, or even housekeeping comes in and they start making noise and you're trying to keep things quiet? We wanted to give them the voice to be able to say in a respectful way, you know what, this is a small baby unit, and if you could just keep your voices down a little bit, or maybe turn off that cell phone. It's really important to this baby's development in order to keep them calm and, you know, they get upset, you know, that kind of thing. So we actually had our executives come down and pretend to be those people, and they got so engaged in it. They said, we should be doing this for every sick patient in the entire hospital, not just babies, but why are we doing this to our sickest, most fragile patients? So it was pretty cool. So I'm going to show you Dia. I may not show this whole thing, it's a little bit long, but I want you to pay attention the way that she tries to pull the information out of people and get them to think about all the, you know, the articles and the pathophysiology of the things that we do that impact these kids. So she's my star. She was here last year. I don't know if any of you guys remember her, but she's great.
Through everything, we're just going to kind of jump right in. How many of you have actually done the transfer of a baby on an oscillator? You have? Okay, good. Oh, a couple of you. Okay. How many people does it take to move a baby on an oscillator?
At least 4.
At least 4, yeah, because you need someone, and that someone has to be a respiratory therapist that's going to man your airway. And then who else do you need? 2 nurses, yeah. That second person has to be a nurse or a provider, and it's not going to be a provider for the most part. But a tech cannot be the one holding your lines. You need to have a licensed nurse actually doing that. Then you need one other person that can be a nurse or a respiratory therapist to actually do the turning of the ventilator. Because remember, when the baby's on the oscillator, that's a very stiff circuit, so the whole vent needs to move. All this is very, needs to be very well choreographed, and everybody needs to move as a unit. So what we want to do right now is actually do this move. So I need a mom. Do you want to be the mom?
Yeah.
Yes, you want to be the mom. Okay. I'm going to have Brian step over. Brian is from respiratory. When the move is made, who's in charge? So we've got, do you want to be the nurse? Okay. Who wants to be her helper? I'll be a helper. You want to be the helper? Okay. And then you want to be the second respiratory therapist?
Sure.
Okay. So who's in charge? Who's in charge of this team? Respiratory. Yeah. So once respiratory arrives at the bedside, he's in charge, and he is going to direct the movements of everyone because he's the one holding the airway. Take it away.
Okay.
So we'll keep.
Yeah.